Sure.
Welcome, everyone. We have the distinct pleasure tonight of welcoming our dear friend, Dr. Don Lalonde, who really needs no introduction. I want to welcome you all. This is part of the Buncke Clinic Virtual Visiting Professor Series. By way of a brief intro, we all know, obviously, who Professor Lalonde is. However, just a few things to summarize. He was, you may not know this, but the first Canadian plastic surgeon to have been elected as chair of the American Board of Plastic Surgery. This was back in 2009, so clearly a significant accomplishment for this to have happened. He has been past president of many societies. He was past president of the American Association for Hand Surgery. He was past president of CSPS, the Canadian Society of Plastic Surgeons. He was also the past chairman of the Royal College of Physicians and Surgeons of Canada, the Specialty Committee of Plastic Surgery. So clearly many, many leadership roles. He's been an invited speaker to more than 200 international presentations and visiting professorships. He's authored over 100 peer-reviewed papers, written probably many more by now. These are probably somewhat dated data, but 10 book chapters. And he has been the CME and MOC director for the section, for the CME section of PRS. So with that, Don, thank you so much for being with us. We're really looking forward to hearing your wisdom. As we all know, Dr. Lalonde has been really instrumental in spearheading wide awake surgery. And I think he's really revolutionized the field in the way it's done. And I think there are surgeons all over the world now who are performing many of their operations that they used to do with general anesthesia under strict local. And this, we have Dr. Lalonde to thank for this. And tonight he'll be discussing injecting local anesthetic without any pain. So you should be able to share your screen with us now, Don.
Great. Are you seeing the screen?
Let's see, not yet. Sometimes it takes a second for it to come through.
It should be. I have hit share screen. I'm seeing.
I see it.
Okay. Somehow it hasn't come through mine, but go ahead. If Greg can see it, then it's then it's working.
Can somebody else please chime in and say that they can see the screen?
Yes, yes, Don, we can see it.
Okay.
Great.
All right. So, but what are you going to do, Babak, if you can't see the?
I think it'll probably come on for me in just a minute, is my guess.
All right. So I'll start, and you just stop me, Babak, if you.
Oh, there it is. It just came through for me as well. Perfect.
All right. Okay. Great. Fantastic. So thank you very much, Dr. Safa and Dr. Buncke, and all of you for having me. It's a pleasure to be here. I do have a. Sorry, let's just go back to that. There is a wide awake hand surgery book, but I'm not making any money on it. All the profits go to the Lean and Green effort dedicated to promoting less unnecessary cost and garbage in hand surgery. But it is a good source with over 150 videos of a lot of the things I'm talking about. In particular, pain-free local anesthesia or minimal pain local anesthesia. There's also a WALANT.surgery website that has all kinds of videos and PowerPoint presentations on how to not hurt people.
Not sore. That's good. Oh, then look, that was the worst of it. So that wasn't sore?
Not a bit. Okay. I didn't feel sorry.
Great.
And so when you're doing a forehead flap, you always go, you know, one side to the other side, and you tumescent all around the vessels. It's okay if you get adrenaline on the vessels. It's not a problem. And I've done at least 30 of these.
How much did the surgery bother you?
Very little, really.
Well, so it's how long ago since we did the reconstruction?
I would say it's at least a year and a half.
I would say probably a 2 on a scale from 0 to 10.
Yeah, compared to going to the dentist.
It doesn't hurt as much as the dentist.
How much the freezing hurt when I put the needle in to put in the numbing medicine? How much did that hurt?
The freezing never hurt at all.
Can you tell me how sore the freezing was, the local anesthesia?
The freezing, I didn't feel it up.
And you saw that the second patient was actually injected by a medical student. Anybody can do this. And, you know, one of the reasons people have sedation is they're afraid of pain. And they're afraid of the pain of local anesthesia. So if you take away the pain of local anesthesia, you just don't need sedation. And none of these people have an IV or monitor.
And at the count of 3, you're going to feel a little sting with a 27 gauge needle. 1, 2, 3. Sorry for the sting. Can you please tell me when that sting is all gone? You didn't get a sting? Okay, that's good.
So this fellow's 95 years old. He's got bad lungs. And what I'm doing is I'm harvesting a skin graft to put it on his head. There he is 2 weeks post-op. And I'm injecting the local in this case.
You always reinsert a needle 2 centimeter or a centimeter inside the white paint junction. So this is clearly very white here. And because it's white, there's functioning epinephrine. So if there's functioning epinephrine, there's probably functioning lidocaine. Did you feel that little sting there? No. So this is a 20 gauge needle. And now I'm through that little hole. I'm going to just twirl it a little bit to make a hole in the skin. Now I'm going to insert this 25 gauge cannula. There we go. Did that hurt?
I did one of these today. So these are blunt tipped cannulas. If you look at the top right, and you can slide through fat with these cannulas, and you can inject local a lot faster with a blunt tipped cannula that doesn't pierce blood vessels and doesn't hurt than you can with sharp needles. And so we injected 150 mils of 1/4% lidocaine with 1 in 400,000 there and 50 mils in the head and did a skin graft. And you know, you really don't want to put people who are 95 years old with bad lungs to sleep if you don't have to. They really don't want to have sedation. So this gentleman here, he came in with this really bad fungating, smelly squamous cell of the scalp, and there were 2 or 3 foci. And here he is at the end of the procedure. We did him wide awake, just like the one you just saw. And I just want you to listen to what his breathing sounds like.
So to take that thing off your head, we took a big piece of skin from your thigh, right? Yeah. And we did that all with freezing. So can you tell me how sore the freezing was? It wasn't sore at all.
You know, I mean, a guy like that, you really don't want to sedate him either. It's just not a terribly safe thing to do if you can avoid it. And he didn't feel the pain of local. And for this man who had a lung cancer, sat up in the chair on his oxygen while I fixed his carpal tunnel, so that for the last 6 months of his life, he was actually able to sleep at night. He wasn't able to sleep. And his daughter said, you know, look, you got to fix Dad's hand because he just can't sleep at night. But he also had a hell of a time lying down and stuff. So we did him sitting up. And for the last 6 months of his life, he was able to sleep. And his daughter sent me a really nice card. So here's another guy who really should avoid sedation if that's possible. My anesthesiology colleagues, they don't want to put these folks to sleep, and they shouldn't. And even if they do a block, sometimes blocks fail, right? So this is an anesthesiologist from England who does WALANT all the time. So WALANT is wide awake, local anesthesia, no tourniquet. And so it's just part of his repertoire. And he made this video before COVID. Keep that in mind.
Rather than just having plan A and plan B, I'm able to have plan C and plan W, plan WALANT. They're extremely at high risk where they can't have a general anesthetic, they can't have a regional anesthetic, and they need something which I know is going to work and is going to be safe for them. So I think it really has helped me in those sort of circumstances where I think, well, I can't do plan A, can't do plan B, and then have to do WALANT. So it's made a big difference to my confidence in where I can apply the WALANT technique, the use of local anesthetic, the confidence to know that actually this technique really does work.
And, you know, anesthetists who have used it and tried it, they love it. And those who haven't, you know, a lot of them are just worried about it for so many reasons. But really, it's the same stuff that dentists give us when we go there. We have no monitoring when we go to the dentist, no blood pressure taken. 2 billion Americans have had lidocaine with adrenaline at the dentist without any monitoring, no blood pressure taken. And if there was a real problem with that, we'd be hearing about it from lawyers every night on TV. So if you think about it, most serious complications of surgery are actually complications of the sedation, not the surgery. I mean, you don't get DVT and overnight admission for nausea and vomiting and malignant hyperthermia and pneumonia from surgery. You get that from sedation. And I know that most anesthetists wouldn't give general anesthetics instead of blocks these days, but still, if you get a general anesthetic, the droplet spreading of COVID and all the crowd that's in the operating room is just not ideal. And less sedation is always safer than more sedation. So the safest sedation is no sedation. In fact, this March, the British Society for Surgery of the Hand, the British Orthopedic Association, and the Ortho Trauma Society all recommended to surgeons that they use WALANT whenever possible in order to not pass COVID around. And WALANT has really taken a giant leap in the world because of COVID. So this is Amir Ahmad, who's in Malaysia, and he's fixing tibias and ankles and patellas and clavicles and elbows and Montagia fractures, and he's doing distal radius and wrists and all kinds of stuff. And he's not the only one, but this patient's wide awake. And there's the patient at the end of the procedure and moving his toes around. Part of his reason is money. You know, in Malaysia, it's just a decreased expense. And so he uses up to 100 cc's of 0.5% lidocaine with 1 in 200,000 epinephrine and just blows it all around and all around the periosteum. You got to get around the periosteum. But for 95% of all hand surgery, and here you're looking at 3 flexor tendons repaired, you're looking at forearm tendon transfers, a perilunate dislocation done by a surgeon in Portugal, and a distal radius fracture by Amir Ahmad from Malaysia. And I show his because he was the first one to publish it. There have been 4 or 5 papers on distal radius fracture now wide awake. But the whole concept is the same as for liposuction. It's tumescent local anesthesia, which means big volume. So 1 to 2 centimeters of visible and palpable local anesthesia beyond wherever you're going to dissect. I mean, what happens when you put 40 cc's there? It goes everywhere. It's like an extravascular beer block. And if you do that on both sides of the wrist, then you can do a proximal row carpectomy very easily. This is Carlos de Pina. I'm not an orthopedic surgeon. I don't do these cases, but a lot of orthopedic surgeons around the world now are, and they can see movement. They can make sure everything is working well. They can see what bones are rubbing where, and here they've decided to put on a little cartilage graft. But let's talk about mundane stuff. So this is a fight bite that I treated myself in the emergency room on a Tuesday night. I don't have residents most nights, so I go in for this stuff. So this is a 48-hour-old fight bite, and he's got cellulitis, and I draw where the cellulitis is. And I inject 40 cc's all around the outside of the zone of cellulitis, because if you inject in the zone of cellulitis, it's going to hurt, and it's also going to be less effective. And then I put 10 cc's in the palm and knock out the digital nerves. And then while the local is working, I do the paperwork and educate the patient. And then I debride in the emergency department. And then I irrigate with bridine and tap water. The difference of concentration of tap water and sterile saline is less than 10:1. Tap water is legislated to be almost sterile in Canada. If there's any coliforms, there's a boil order. And so he's not feeling this at all. And I'm irrigating the wound. Never went to the operating room. He went directly from the emergency department to be admitted for IV antibiotics when we still did that stuff. And here he is the morning after in the hospital. All the swelling is gone because he was totally awake and totally listening to all my education. Because these patients are totally educated. I spent a lot of time talking to them about how to take painkillers, how to do pain-guided healing. And here he is at a month with all his range of motion back. So everything from the mundane to the more serious, you can certainly do. Let's just see here. There we go. And certainly things like cubital tunnel release, I use 60 cc's of 0.5% lidocaine with 1 in 200,000 epinephrine. There you see the tumescent local anesthesia. You need visible and palpable local anesthesia everywhere you're going to cut. And then we let her bake for half an hour, and then we do the surgery. And the visibility is good. And if you don't have all the anesthesiology and tourniquet equipment, this is a really good position to do these operations. The visibility is a lot easier. I always use buried 5/0 monocryl sutures, never have sutures to take out. Everything's all absorbable, carpal tunnels and everything. Now I want you to look at this guy's face, okay? So he had a really sore shoulder. He looks very comfortable, doesn't he? Because he is. In this position, he's comfortable. But watch when he brings his shoulder down at the pain. Oh, in mid-abduction, he had a terribly painful shoulder. And in the days when I used to do these asleep, that's how we'd put them. And they'd wake up and go, geez, Dr. Lalonde, I don't know what the hell you did to my shoulder, but it hurts way more than my elbow. And you can also do them on their side, in behind. You can do them prone. You can do, look, when people are comfortable, you can do them any position you want so that they get comfortable.
If the patients are comfortable.
Here's a prone case. We're doing these in the operating room now with field sterility. That's a whole other story that I'm not going to get into now, but there we are, not in full gear, but this is in the main operating room. So we're doing main operating room cases with field sterility now. There you go. So you can also do Lacertus. So this is proximal median nerve compression. And I inject 50 cc's of 1% with 1 in 100,000. And this is for people who still have symptoms after carpal tunnel release. A lot of them are blocked by the Lacertus. I don't redo carpal tunnels anymore. And especially if you examine them, FPL, FDP2, and FCR power, and if they're weak, and if they have palmar cutaneous nerve numbness, that means it's proximal median nerve because it's proximal to the carpal tunnel. And if you go in and divide the Lacertus, a lot of these patients get better, including me. I had this operation. I had a carpal tunnel release and it didn't make me quite better, but after my Lacertus was released, I was good to go. And you can measure their power on the table. This is what the Lacertus fibrosis looks like right here. It's just like the transverse carpal ligament. It's the same problem. It's a tight band of white stuff at a joint squishing the median nerve. It's not rocket science. And so there I am dividing the Lacertus. And when I had that done to myself, it felt like I unbuttoned my zipper and fly after a turkey dinner at Christmas time. It just felt wonderful. So the usual tumescent local anesthesia recipe starts with 50 cc's of 1% lidocaine with 1 in 100,000 epinephrine. And we know that's extremely safe. There have been 3 papers in the liposuction literature showing us that we can use 30 to 35 milligrams per kilogram and still have safe blood levels of lidocaine. And so then if I need more volume, I just add saline. So if I want 200 cc's to do a forearm case, I just add 150 of saline. And that is ridiculously safe. And that's why they don't need monitoring, because the 7 milligram per kilogram thing was invented in 1948, just before the dinosaurs became extinct, when lidocaine was invented.
At the count of 3, you're going to feel a little poke, and I'm going to ask you to try to not move. 1, 2, little poke. That was the word for it.
And I really hate needles, just despise them. This needle was nothing, absolutely nothing. Kind of pressed on my hand 3 times, and then he put the needle in, and it wasn't uncomfortable. And then in a few seconds, it all went away.
I felt the first poke. It was not painful. Not even a twinge, no discomfort whatsoever.
No discomfort whatsoever. There's a tiny, tiny prick, which is not even worth mentioning.
I didn't need to have any blood tests done. I didn't need to have a chest X-ray done.
No tests. Well, I did not have to go in for tests. As opposed to waiting in line and having tests and then going back another day for surgery, I had to do none of that.
Why anybody would want to go into a hospital and actually subject themselves to a pilot test and everything for no reason just makes no sense to me.
I had my own clothes on and I knew to wear a blouse that we could just roll the sleeve up a bit. I didn't need intravenous. I had no tourniquet on my arm.
I ate before the surgery. I ate directly after the surgery. Like I said, I was not nauseated whatsoever. 0 pain before, during, and after the surgery. That was fantastic. Takes an hour and 15 minutes to do, and then you're back to your daily routine afterwards.
I suppose the whole time I could have been here would have been meeting hour at the most.
You know, I don't want an anesthetic unless I have to have it. Well, because it's the anesthetic that gives you the problems in the recovery period, much more so than whatever it is you had the operation for.
For one thing, when you're out, you're out. You have the wake up period. A lot of people are sick. Then the drugs that they give you to stop you from being sick and for the pain and all the rest of it, there was none of that.
And I have a few medical conditions and I am on medication. Nothing changed.
I found it very informative and very comforting that I was able to speak to the surgeon, to have him tell me what I should do, what I should not do afterward. It gave me all that information and I could hyper-focus on that information at the time because I wasn't doing anything else.
My questions were answered while I was there.
So I paid strict attention, took it to heart, did exactly what I was supposed to do, and I was amazed at how well it turned out.
You know, more than 95% of Canadian carpal tunnels and trigger fingers and de Courvey and all the small stuff is all done with field sterility, no tourniquet, wide awake with adrenaline. And for most Canadian patients, if you ever said to them, you know, you're going to come in and have sedation and tourniquet and all that, they'd look at you like you were from outer space. So one of the keys is to wait at least 30 minutes. There's level 2 evidence in humans that it bleeds 3 times less if you wait 30 minutes after adrenaline injection than if you wait 7 minutes. And so I inject 2 or 3 patients and then I do the first one and then I inject the 4th one and then I do the 2nd one. And that way there's no time wasted at all. But it's like flying an airplane. You always have to make sure you got enough fuel to land. So you want to keep enough tumescent local anesthesia in reserve just in case. Having said that, I hate top-ups. You should never have to top up local anesthesia because people are feeling pain during your surgery, any more than patients should never wake up from a general anesthetic. It should be a never event. And if you put in big volume, it's gonna be a never event. It's all about the volume. Just don't wuss out on the volume. So let's talk about why and how local anesthesia should not hurt in 2020. And if you're still hurting people when you inject local anesthesia, please read the papers, watch the videos. The goal is they barely feel the little sting of a 30 gauge needle. And once again, 0 event for top up local injection and 0 pain during the surgery. It's all there, just read it. The other thing is, you would like for your patients to think that you're a bit of a magician, not a torturer. And you know what? A lot of patients think that my medical students and residents are magicians. It's wonderful. They, after the medical students and the residents put in hole-in-one local anesthesia into the patients are delighted to have them do anything they want because they think they're magicians. It's wonderful. Anybody can do this. We're not special here in St. John or in Canada. I'm not that skilled. If you follow these 13 simple rules, it's not going to hurt. So the first one, let's go through these. The first one is use tiny needles, okay? And never say, well, my hospital doesn't have these. Every hospital has a woman or a man who orders needles. Go find that person and say, instead of 25s, can you please order me some 27s and half-inch 30s or even 31s? So I never use 25s pretty much anymore. My go-to needle is a 27 gauge needle, 1 1/4 inches, but I'll often start with my secret weapon, which is a 30 gauge half-inch needle on a 3 cc syringe. Those are great. They're great for digital blocks. They're great for sensitive patients, because I know we have sensitive patients in Canada too, you know. A lot of people say, oh, Canadian patients are tough and American patients are wusses. I don't believe that for a minute. I think that we all come from Ireland and China and God knows where. It's just the way it is. And the smaller needles hurt less going in, and they force me to slow down and be patient a little bit. So this person is having hyaluronic acid fillers, and there's no topical numbing stuff. You don't need any of that foolishness. You just need a tiny needle. So this is a 31 gauge needle, and watch the sensory noise.
1, 2, 3.
1 to 10, Susan. 0.
0 pain.
1, 2, 3.
0.
Pushing the skin into the needle instead of the needle into the skin helps a lot. 1, 2, 3.
See that? You push the skin into the needle.
0.
Push the skin into the needle. It hurts less. Okay.
And that's when you don't slow it up. And Arthur Swift taught me that. It's unbelievably good. And so tiny needles, push the skin into the needle, get people to take a deep breath. All these things are forms of sensory noise. It's like listening to a baby cry at the Chicago O'Hare Airport at 2 in the afternoon in the old days, instead of listening to the same kid cry in your bedroom at 2 o'clock in the morning. Same volume, but boy, it sure sounds louder. So don't blast it in quickly, slow down, and never advance a sharp needle anywhere that's not numb. So never let the needle get ahead of the local. You know, in the first 15 years of my practice, I used to, and they'd feel every little thing because the sharp needle tip is hitting all these live nerves. That's what you really do to people you don't like. Never do that. Always have at least 1 centimeter of visible or palpable local ahead of the needle. You don't need to draw back. You always think in your head, blow slow before you go. Blow slow before you go. You know, in the emerge literature and in the anesthesia literature, patients are getting 100 milligrams of lidocaine IV in multiple trauma so to take away their pain. So it's okay if you get a little IV blast, guys. And the half-life of epinephrine is 1.7 minutes when it's IV. So
Great. So you didn't feel the sting of the needle go in. It's not hurting right now, right?
No.
Okay. So now blow slow before you go. Can you back up a little bit so you can see my syringe? You can see the stuff going out. Thank you. Blow slow before you go. I'm always thinking that in my head as I advance the needle tip. I always want at least a centimeter of visible or palpable local ahead of my sharp needle tip. Because if I just advance my needle tip into this pink area up here, she's going to feel a sting. But if I have a wheel of local anesthesia going ahead of me, then she's not going to feel sting. Can you please tell me if you feel any sting at all in the next few minutes? Because I'm scoring myself here. And I can feel the local advance ahead of my needle tip. If you're always saying that in your head, blow slow before you go, it kind of helps you remember to be patient, because surgeons in general are impatient. We want to do everything yesterday faster, but it doesn't help patients get rid of their pain. Now I'm feeling it inflate up here, so I'm going to stop advancing my needle. Still not hurting, eh? You're still going to tell me, right?
Yes, I will tell you.
You're going to interrupt me.
that's called a sweet spot. When you feel it inflating, you can stop advancing the needle because it's going where you want it to go. It's like when you're examining a candidate in an exam and they're really good, you don't have to interrupt them. If you're feeling it inflate with your left index, so I'm always feeling, I'm like a spider there. And when I feel it inflate, I stop moving. The whiter my hair gets, the less I move the needle. Buffer acidic local with bicarbonate. The pH of this stuff is a range of 3.3 to 5.5 with an average of 4.2, and that's 1,000 times body pH in acidity. That's why it burns like hell. So if you add 1 cc of this to 10 cc's of that, you take the pH down. And so I always add bicarb to my local. The next thing is insert the needle perpendicular to the skin. Don't inject in the dermis. And 2 hands on the needle, on the syringe, with your thumb ready on the plunger. I've been injected well over 80 times by learners, residents, medical students. And there's the one-handed wobblers, okay? They're injecting with one hand. You feel every little wobble of that needle until the needle site gets numb. And they don't even bother to numb the skin where the needle's in. They just keep wobbling. So do it like microsurgery, you know, stabilize the syringe so it's not wobbling. Have your thumb ready on the plunger before you go in and try to go in perpendicularly, because there's level 2 evidence that if you go in perpendicularly, that it hurts less than if you go in at 45 degrees. And it hurts even more if you go parallel to the skin. Why? Because nerves are like trees with leaves in the dermis and trunks and branches in the fat. And if you hit a lot of leaves, it's going to hurt. So try to go perpendicular. And for the same reason, you don't inject in the dermis and show yourself peau d'orange. It works very fast, but it hurts like hell. You want to be in the fat underneath. And as soon as you're in, so you can see a little bit and then pause and ask them to tell you when the sting is all gone so that your needle site is numb. Now let's a little bit more about sensory noise.
Important rule about the freezing is the don't move rule. If you pull back, then the needle comes out. I have to stick it in 2 times. If you don't move, it hurts just 1 time, okay? So try not to move. And at the count of 3, I'm going to put the needle in, so don't move, okay? 1, 2, 3. That's cool. I feel it, but it's not. Sorry for the little sting there.
Nothing at all. I'm surprised. Compared to what I've been putting through, like with this.
So you were kind of petrified of the needle, right?
You have no idea.
Right, because you hate needles, right?
Can't stand.
Right. How much did this one hurt?
Out of like 1 to 10?
Yeah.
0.2.
Okay.
0.2, not even 1.
Okay, good.
Like really 0. I barely even felt it.
Good.
This guy was petrified. He's, oh, you're going to put me to sleep, doc. You can't give me a needle. I said, can I film you? Because
Count of
I
three,
want to
don't
show
move,
you
okay?
it's not going to hurt.
1, 2, 3. Good. You hardly moved a muscle. So at the count of 3, just try not to move, okay? You're going to feel 3 little pinches, okay? 1, 2, 3. Very good. Walk away.
What my dad says
Yeah.
is always take a deep breath and hold it for a little bit until it doesn't hurt.
That's a great idea.
Yeah.
So at the count of 3, I'll tell you when to take a deep breath, okay? Okay, ready? Okay. 1, 2, take a deep breath right now. Oh, what a good girl you are. Oh, what a good girl. It's almost finished hurting. Can you please tell me when it's not hurting at all anymore?
Not hurting anymore.
Oh, beautiful. So at the count of 3, try not to move. At the count of 2, take a nice deep breath. Can you do that? Is that okay? Yeah. Okay, good. 1, deep breath. Don't move. Good.
Today I did a newborn baby with extra digits on the 5th finger, and the sensory noise there is feeding. So the baby came in, was hungry, started sucking on the bottle, and I'm touching the hand and 30 gauge needle, 1/2 inch on a 3 cc syringe, and babies kind of go into a trance when they're sucking, especially newborns. This one was like 2 weeks old. The fresher they are out of the chute, the better it is. And so at 2 weeks old, they get into this trance, and that's when you just pinch. You're touching it and you're pinching it a little bit, and then finally you pinch and push the skin into the needle. He didn't even light. And I injected both sides, nipped off the nubbins while he fell asleep. The best anesthesia ever. He's just sleeping. Cauterized the bases, and that was it. I've been doing that for years. So always reinsert needles in numb skin. Never put a sharp object in pink skin. It's got to be tumescent if they're pale like I am, or if they're dark skin, you just have to see that tumescence because you're not going to see the epinephrine vasoconstriction as well. And always inject too much volume instead of not enough volume. It's one of the biggest sins is not enough volume. And so this is how I do facelifts. This is a 3-way stopcock hooked up to an IV. This is a blunt cannula, and you always reinsert the sharp needle into an area that's clearly white. And it doesn't matter what you're doing, whether it's cosmetic or reconstructive, it's always the same story. So I'm 1 centimeter inside white tumescent skin when I reinsert the needle. Ask.
Well, I'd like you to please, while I put this, know what you're feeling. If I'm hurting you a lot, I don't know. And if I don't know, I can't get better. So you're going to feel the first little poke probably when I put the freeze. Tell me when the first sting is gone, and every time after that, I want you to tell me if you feel any more pain, because I don't know if you don't tell me. So you're going to feel this first little poke here. So at the count of 3, I want you to try not to move. At the count of 2, I want you to take a nice deep breath. Can you do that for me? So you're going to pinch 3 times. 1, deep breath. Don't move. Great. Thank you so much for not moving.
So is that still stinging in there?
Don't feel it.
You don't feel anything?
No.
Did it sting when the needle went in? A little wee bit. Okay. So here's what and right now it's not stinging. Okay. So can you please tell me if you feel any sting at all in the next 10 minutes?
So if they only feel the first poke, I score a hole in one. If they feel pain 2 times, my medical student scores an eagle. 3 times, my resident scores a birdie. We all score ourselves every time, because if you do that every time, you're going to get better and better. If you're not measuring what you're doing and competing with yourself a little bit, trying to get better, you're not gonna. And we published this paper 8 years ago now, where 25 consecutive medical students and residents were taught hole-in-one local anesthesia and then scored by the patients on their first carpal tunnel injection. 75% scored a hole-in-one, 25% scored an eagle, felt pain twice. Nobody scored a birdie. So anybody can do this. It's not that we're particularly skilled. So filler cannulas, I showed you a little bit. This is me, and that's a filler cannula. That's the blunt tip. And I cannot feel that thing underneath my skin. And when I put in fillers, I love using these. They don't bruise, they don't hurt. If you hit an obstruction, that's because there's a ligament there. If there's a ligament, there's nerves and blood vessels there. So if you ram through, you might get a bruise and you might get pain. But if you just back up like my resident is doing now and find a clean path through the fat, it really doesn't hurt. And so that's how I do blepharoplasties.
Just try not to move here. It's going to sting just a little bit, okay? 1, 2, 3. That's it.
Way better than the dentist. Okay, good.
Here we're dissecting underneath the orbicularis muscle. When you're doing deep dissection, you have to make sure that you have local anesthesia where you're going to be working to avoid pain and to decrease bleeding. You certainly can cut right down onto bone or wherever you need to, as long as there's local anesthesia there. One helpful tip is to use bipolar cautery instead of monopolar cautery, because bipolar cautery doesn't have electricity conducted to deep tissues that may not be anesthetized.
Yeah, so tomorrow you go ahead and get in the shower. Let a little water run over your wound. But the only thing that I really want to touch these wounds is water.
Okay.
Especially fingernails are not welcome.
Right.
Fingernails are full of germs.
Mm.
And if you, I don't think you need ice or heat or any of that. You don't need to play with it. Just leave it alone. You know what? Treat it like a sleeping baby. Don't disturb it.
Okay.
You know, the intraoperative patient education component for me is one of the most important things. And that's why I want zero sedation, because if they're sedated, they can't remember. And I want them to remember. I want to educate my flexor tendon repair patients on how to behave so they don't rip their repair apart. The intraoperative patient education component has been the single most important part of awake surgery in my lifetime. And there's a paper on how to do this stuff. Louis Vasconez started wide awake facelifts in his 60s, and I started in my 50s. And I'll tell you, the business of no gagging and coughing on a tube or vomiting, I'm convinced it's decreased my hematoma rate. And I don't do a lot of facelifts. I'm not a big cosmetic surgeon. I'm a small city plastic surgeon. but I like them a lot more. They're a lot more fun now than they used to be, because the part that I used to hate the most was watching patients wake up and being extubated and going, you know, and I had visions of all the little capillaries bursting. Now they just sit up quietly and go home and have one glass of wine, and I'm delighted. So 100 cc's per side, 100 cc's per the neck. And so if you have 300 cc's, you've got plenty. I use 9 milligrams per kilogram for lidocaine with epinephrine, and you got to know that a lot of that just diffuses out as soon as you make your incisions.
I very little pain, just the initial needles, which weren't very bad. After that, I felt very little.
Do you have a choice between being awake or asleep? Next time, what would you do?
I would choose this way.
And you know, most of the surgeons are like that, or most of the patients are like that. But you know, this isn't for everybody, okay? I mean, if you are a surgeon who's kind of a little bit rough around the edges, or if you just want to operate in quiet and never talk to anybody, this might not be for you. You know, I think you have to like talking to patients, and I do. I get a bang out of it about educating them and telling them how to stay out of trouble, because they love the whole surgical experience if you make it pleasant for them. And some people are just afraid of needles, right? So I remind them that if they get an IV, for most anesthesiologists, that means a 20 gauge without any pre-freezing. And they get another 20 gauge needle in their arm pre-op for blood tests, a lot of people, whereas I'm going to be using a 27 or 30. And you can do mini tummy tucks the same way. Once again, you want to use bipolar cautery so that those perforators that are going down through the rectus muscle that feel pain with monopolar cautery are not going to be affected. And you can do subglandular breast augmentation that way. I'm not a submuscular fan. You just watch the pendulum swing back. It'll swing back to subglandular. It's swung 2 or 3 times in my 36 years in practice. And the Brazilians are all going subglandular. Anyway, I like subglandular, and so I do these little these little dots with sharp needles and then join them with a cannula. And I blow in underneath 500 cc's of tumescent, up to 500 cc's of tumescent local anesthesia per side. And the patients sit up and go home.
We've just shown you with a mirror and on the camera. What do you think? Is that okay?
Oh, they look great. First time I've actually been able to see that nipple.
Yeah, well, that's good.
So nicely, so.
And this here is a little bit wider than this side, but it's the freezing in there that's doing that, and there's also freezing in here that's pushing it down a little bit. I think that's about as close to perfect as we're going to get.
Yeah, no, they look great.
I think that the patient seeing the result before they leave is also very, very helpful, because it creates a realistic expectation of the result, especially for things like Dupuytren's and tenolysis. I mean, they know what they're going to get. And tendon transfers, they see their tendon transfer move before they leave the operating room. I think that's a big deal. So this lady looked at herself in the mirror. That was her talking about her result. So you can kill patients with too much lidocaine. I mean, it has happened. So just don't go there. And I stick with 7 milligrams per kilogram because it's extremely safe. I occasionally will flirt a little higher than that, but you know, you have to be careful, and you have to understand about intralipid rescue. Intralipid is really more for bupivacaine. For the record, I hate bupivacaine for a whole bunch of reasons. But You certainly, if you're going to use bupivacaine, you need to understand intralipid rescue because you can really kill people with that stuff. It's very dangerous. It stops the heart. I've never actually had to use intralipid rescue for lidocaine, but I'm aware of it. I mean, I've never had to use naloxone for morphine either, and I've never had to use phentolamine for adrenaline in a finger, but I know how. I think it's a part of being safe. So here's a little useful thing, especially with cosmetic patients, but even tendon transfers. If you just put in 200 cc's, they're going to have to pee. So you never give them an IV because then they have to pee. But you let them go to the bathroom between as soon as you're done your local and when you start. And that gives the epinephrine a little time to work. And it gives you at least a couple hours for most people that you can get most of your surgeries done. Most people are good for 3 hours without needing a catheter. And then finally, always inject from proximal to distal because the nerves go proximal to distal. So when you're doing wide awake forehead flaps, you start below and work your way up on the forehead. In the forearm, you start proximal and go distal. So this gentleman cut all 8 finger flexors 6 months before I met him. I did this case in Honduras a year ago, back when people still used to fly, BC. So what we did was we took all, first I injected 110 cc's, always from proximal to distal, and I scored a hole in one for this gentleman. And then we took 4 FDS grafts and put them through the original A2 pulleys. Yes, the original A2 pulleys. You can lift those out of scar at 6 months, at 18 months. You just get right on the bone and lift them out of the scar. I think Hunter rods are obsolete. I don't think you need them anymore. Anyway, always from proximal to distal, see the advancing wheel. Here's how you dig the A2 pulleys out of the scar. You go where the pulley likely starts, where it likely finishes. Get down there with your Stevens tenotomy scissors right on the bone and just do the little haircut technique with open and closed, open and closed. And first thing you know, you've got this tunnel that easily admits a flexor digitorum superficialis graft. And this guy had 4 FDS grafts doing nothing in his forearm. So, and he had 2 centimeters of active excursion of his FDP muscles. So we used the FDP muscles that we saw working very well. Whoops. And sorry about that. Let's take that along to here. So that's a schematic of what we did, inserting the 4 FDS grafts through the original pulleys. The first attempt wasn't tight enough. The second attempt, we got it right. And then we got all 4 fingers. I'm sorry, this is a little bloody, but we were at the end of 4 hours. I was having to do top-ups because I had never done this before, but what a fantastic thing it was to do. And here he was at 3.5 months. I'm doing therapy with him from Canada to Honduras on WhatsApp. So the moral of the story here is anybody can give almost painless local anesthesia. We can all do it if we just take a little longer to inject. Compared to the turnover time in our operating room, I got to tell you, it's well worth a couple of minutes to inject a little slower and to learn from your patients. Score yourself. The usual causes of painful local anesthesia are injecting big volumes too fast, moving the needle too fast, and not injecting enough volume is why you have pain at surgery. You should never have pain at surgery. And so if you're still hurting people with local anesthesia injection, please stop. You know, it took me 20 years of hurting people before a young dermatologist moved to St. John here, a Mohs surgeon, and taught me how to inject so it doesn't hurt. And, you know, for the last 16 years, I have not been hurting people. So it's never too late to stop hurting people, okay? Now, I think it's important that you understand where patients are coming from. They're afraid of two things that they know of. They're afraid of the pain of the local anesthesia because they've all been hurt at the dentist and they've all been hurt in emergency departments by people who don't know how to put in local properly. And they're afraid of the pain of the surgery. And they're afraid of the unknown. They just are afraid of, they don't know what. But fear of the unknown is one of the biggest problems that we have to deal with. So when I talk to them before the surgery, I promise them that they're going to be amazed that the local anesthesia will hardly hurt at all, even if I have one of my medical students or residents inject the local. And certainly it's going to be much less pain than the pain of an intravenous insertion for sedation. And I promise them that they're not going to have pain during the surgery. But then I have to deliver on my promises. You have to deliver on your promises. In fact, you have to under-promise and over-deliver, always. So why do people get sedation? Well, they get sedation because they want to solve their surgical problem and they want a pleasant experience. I got to tell you that wide awake surgery is a lot more pleasant than 7% nausea and vomiting, big needle insertion, unnecessary tests and consultations and urinary retention, and all these things take time. You know, they got to take time out of their job to go see a preoperative consultation and get a babysitter to go get the tests and all this stuff. And in 2020, pure local anesthesia can be a much more pleasant experience and much safer in many cases. But there are two common problems with wide awake surgery, and the first is the adrenaline rush. And in my experience, about a third of the patients get an adrenaline rush. And so you got to warn each and every patient after each injection. You might feel a little shaky, like you've had too much coffee, because there's a little adrenaline in this stuff. And you may get a little adrenaline rush, like you're afraid or you're ready to run the 100-yard dash. If you get it, it's temporary, it's normal, and it's going to go away all by itself in 15 or 20 minutes. So don't worry, be happy. And you are not allergic to it, because so many people who get an adrenaline rush at the dentist walk out thinking they're allergic to lidocaine, and they're not. The second problem is fainting. And fainting happens because there's not enough blood going to the brain. So you avoid it by never injecting patients sitting up, always inject them lying down. And recognize it, because even when they're lying down, they say, I'm not feeling very well, or I think I'm gonna be sick, or they get pale between the eyes, or they start to yawn because there's not enough blood going to their brain. So the solution is get more blood to the brain. So the first thing you do is put your hand right under their knees and get their thighs up. So the 2 liters of blood in their thighs runs directly to their brain. Next, take the pillow out from under their head, more blood to the brain. Put it under their feet, more blood to the brain. Then put them in Trendelenburg. And you saw that that whole thing, which was a real-time event, took me about 15 seconds. This lady is deaf. This is her signing interpreter. The deaf lady told the signing interpreter she wasn't feeling very well. And I had a medical student in the room. I said, start shooting. Please film this right now. And that's how we caught it live. But you saw how fast I do it, because I do this at least 1 or 2% of the time. And you got to be ready to do that. And after you got more blood to the brain, then you can let the nurse go for the cold, wet face cloth, which does absolutely nothing for cerebral blood flow. And as far as I'm concerned, does nothing, period. But this works. And then you got to leave them like that for 10 or 15 minutes. If they sit right back up, they're going to get it again. And other limits of wide awake surgery I've mentioned, but it's worth mentioning again. You know, you got to have a little bit of gentility and kindness. And if you don't feel that way, just don't do this. Because, you know, if you can speak to patients and talk to them about their dog or their kids or, you know, a hike that they took, it becomes a very pleasant experience. And, you know, most of my patients love going through the surgery. A lot of them say after surgery, you know what, people ought to put this on their bucket list. Instead of something to be feared, it's actually an adventure. And people love an intraoperative demonstration of their anatomy. A lot of them like that. Now, if you're interested in this kind of lecture, or you want to know more about flexor tendons or extensor tendons or finger fractures and specifics of that, I've just given a couple of hours of lectures, and just Google YouTube, Lalonde, and Pulvertaft. There's a Pulvertaft series out of England. And I talk, because flexor tendon repair is totally changed in 2020. You got to be venting pulleys. You got to be doing them awake. You got to have a bunched up repair. You can vent the A2 pulley. As long as you don't vent a total of more than 1.5 to 2 centimeters of pulley. And now you can fix boutonnieres. There's a lot of very new, exciting stuff that has been generated by wide awake surgery. So I'm going to stop there because we're exactly an hour, and I think that's the time that I was given. And so I don't know how to stop sharing.
You know what, I'll just go back to the slide that I had for you, and then we'll open this up for questions. Let's see here.
So if you stop
there we go. Excellent.
Okay,
well, Don,
great.
thank you so much for a phenomenal talk. And the cases that you showed are simply amazing. What you can do with local anesthetic. I think it definitely surpasses what many of us think is the limit, if you will, of doing cases under strict local anesthetic. So I want to congratulate you on that. And one of the points that you made, I think, is a really good one, because you mentioned that, if you're, a little rough around the edges, either from a technical standpoint or from a personality standpoint, this may not be for you. And I think that those of us who know you personally know that you are just simply a very, very, very nice and patient person. And I think that's one of the reasons why I think this is especially powerful in your hands. And I think obviously your patients are very lucky to have that temperament in their surgeon. And actually, just a small story from myself, actually, you were one of my board examiners, if you recall, many years ago in my case books. And I just remember walking out of the session, I was like, wow, that was really pleasant and really nice. And so I think that's just, helps you do these types of surgeries. Greg Buncke, I know you're on the line. I wanted to open it up and have you make a comment or a question.
Yeah, let me see if I can get on here. Can you see me?
Yep, we can see you.
Hey, Don, that was great. Thank you so much. Every time I hear your talks, I learn something new, and it's really fun to hear it. And you have been a real inspiration for many people, including me, in this. And I've really taken a lot of what you do to heart. I just want a couple specific questions. So you never use a tourniquet now at all? Is that correct?
Pretty much. The only time I'll use a tourniquet is if I have something like a sarcoma, for example, or a serious vascular malformation of the forearm where you really got to see, like a big sarcoma in the forearm. But
yeah,
there's not many things really.
And then in situations where you're giving a lot of adrenaline with your lidocaine, do you ever worry about patients who have sort of arrhythmias and things like that? Are those patients people that you may consider not using the lido with epi and do something?
That's a really good question, and I'm going to take advantage of the fact that I can see Teddy Presationo's name there from Indonesia. So if you are worried about arrhythmias, you can drop your epinephrine down. Teddy, who's on the line here, who, by the way, is a very gentle surgeon, who works in Jakarta, he sings to his patients during the surgery. And it's lovely to watch, actually. It's awesome. But Teddy uses 1 in a million epinephrine, and he's published all kinds of papers on this. And his visibility is just fine. And he does skin flaps, and he's been doing this for years. So the answer is yes, you can drop the epinephrine if you're worried. But I have yet to have a significant arrhythmia or a problem, Greg. I just haven't had it. And so I know Peter Amadio did have one, but whether, you know, maybe it's because he was on the monitor that he saw it, and, you know, and the patient was fine. They didn't do anything, it just passed. And maybe if I monitored my patients, I'd see it. But it just, like, I think all the millions of people who have dental anesthesia every day with no monitoring in the United States. And you're not hearing lawyers every night saying, hurt by your dentist, call William McDentist, you know? I mean.
And then using, you know, a lot of our patients want sedation. You know, they don't want to kind of remember anything that happens. Do you have any discussion that you have with those patients that ask about that, or do they in Canada?
Sure they do. And, you know, if they really want it, I give it to them. I mean, I don't force anybody to have anything. But, you know, I say to them, well, have you ever had sedation before? And I just get them to tell me their stories. And it's amazing how many people have had either nausea or vomiting, or, you know, they couldn't pee after surgery, or, you know, they had this problem or that problem. And, you know, or they got kids, and so they got to, you know, make another appointment, or they have a parent, an elderly parent that they have to look after. And if you have sedation in Canada, you have to have a babysitter with you. You cannot be the responsible adult in the house. You need somebody to babysit you. And for a lot of people, they don't even think about that when they ask for the sedation. And so I'll point out the obvious advantages. And, you know, if they don't want to do it, they can have the sedation. I'm good.
Sure. Thank you again. That was great.
Thanks, Greg. We had a couple of questions in the comment section from Professor Bala from Chennai, India, who has been kind enough to join many of our lectures at very early hours in India. Professor Bala, the first question that he had was with how do you manage postoperative edema? Do you use steroids in conjunction with your surgeries, even the wide awake ones?
Yeah, that's a great question. No, I do not use steroids. And by the way, if I want to give antibiotics, I give them Keflex because it has 90% of the bioavailability of cefazolin. And so they just get a pill. Yeah. But no, I don't use steroids. But you know, it's a great question, and thank you for that, Dr. Ball, because especially for hand surgery, the most important thing about swelling is to keep it up. And if they just wake up from being sedated, they just walk out going like that, especially if they're on bupivacaine, because it doesn't hurt at all for 7 hours. And then they have incredible swelling. But I tell them all, because they're awake, I say, look, when I see you in 4 days, your hand is going to be like a report card. If you come in and there's no swelling at all, I know you've been up like this, treating it like a sleeping baby. Don't disturb it. No walking around like this. No. None of this. No. Because this and this cause bleeding in there. And if you bleed in there, you get a clot. And it takes your body weeks to get rid of a clot. And the swelling will slow down the blood flow and take you longer to get better. And if you keep your hand up and quiet, treat it like a sleeping baby, and come back and see me in 4 days, I'll know if you've been doing that. It's going to be like a report card. And when they come in at 4 days and there's zero swelling, because there usually is, unless there's some kind of a Yahoo who's on narcotics before the surgery and walks around doing that no matter what I say, then they're not swollen at all. And so I say to them, thank you so much for keeping your hand up, because I know you have, because look at it, it's not swollen at all. It's your report card.
Right. Great. No, that's a great point. And then the other question that Professor Bala had was, you're injecting a fair amount of volume in these cases. And so how long does it take for some of that volume to dissipate so that, when you operate, it's not interfering with the surgery?
That's a great question. And I think if anything, the volume does a little bit of tumescent dissection of your tissues, and it's really easy to see. And I find that most of the volume's actually gone by the end of the case. It comes out, it's either absorbed or it oozes out. I mean, it's clear water. It doesn't obstruct your visibility.
Yeah.
And certainly, you saw the guy with the fight bite. The morning after, there was zero swelling there because he kept his hand up all night. And this is usually what you see. Unless they have a bandage that's on too tight, there's no swelling.
Right. Great. And I'm actually really glad that you mentioned Teddy and his great work in local anesthetic and with surgery, because we actually have him on next week to discuss.
Great. Oh, you're going to love Teddy. Teddy's
great guy. Yeah. So we're looking forward to his talk as well. So thank you so much for that. Don, thanks again for taking the time. I know it's quite late over there. Hi, Teddy. It's always good to see you. Thanks so much again for taking the time. I know it's much later over there. You're 4 hours ahead of us, but we really do appreciate you taking the time and educating us. And you've really been a trailblazer in this whole field. And I think you've really helped advance it. Hi, Professor Bala. Thank you so much for joining us. Appreciate it.
Thanks for.
And then just a couple of housekeeping items. For tomorrow morning, we have a fantastic lecture by Dr. Scott Cozen from Shriners in Philadelphia, who will be giving us a lecture on building a pediatric free tissue transfer center and the first pediatric hand transplant. So please refer to our website at microsurgeon.org for the details of that. And again, Don, thank you so much for being with us. We look forward to hopefully seeing you in person soon.
Okay, nice to see you guys.
Great.
You're gonna love
so
Scott Cozen's talk too. He's great.
Yeah, he's fantastic. Always gives a phenomenal talk.
All right. Good night, everybody.
Thank you. Take care. Bye-bye.
Thanks, Don. Bye-bye.